Here we go, another Fireside, Module 3. I said last week Module 2 was the best, but I think this one's going to be a little better. I have two colleagues and very good friends, Dr. Westrick and Jeff Marasek here this evening with us. Thank you guys for coming. For those of you been here for Module 1 and 2, this one is going to be pretty intense. Not going to lie, we have some intense surgeons here. So let's get started. So again, we're going to go over subtroch fractures with Dr. Westrick and Dr. Marasek.
Sharing a screen, but these are our disclosures for the talk today.
This evening, again, we're going to go a maximum 90 minutes. We'll do an introduction by myself, and Dr. Westrick will go over some cases, and then we'll have some discussion throughout the cases, and then Dr. Marasek will present his case. And then he has a good reconstruction case as well. And then we'll talk about two journal articles about the feasibility of open reduction of subtroch femur fractures. We'll do a follow-up with questions and then a wrap-up. So the learning objectives at the end of this session, you'll be able to describe typical deforming forces in subtrochanteric femur fractures. And I think with all the cases that we're going to go over this evening, it's going to be really important to understand those, because you're going to have to neutralize those forces or obtain an appropriate reduction to get appropriate alignment. And you'll see with the cases, subtroch femur fractures are very sensitive to malreduction in terms of complications. And then again, talking about how to reduce them and how to obtain the proper starting point. So this is one of my cases. This is a 30-year-old high-speed MVC. He has a very comminuted subtroch femur fracture with a very short segment. And maybe I'll just start with Jeff and asking him, what goes through your mind with seeing this case? What do you think is going to be difficult for you in terms of what's written on the slide, length rotation or coronal sagittal plane?
So I think this will be difficult for all of those, right? Anytime you have a fracture that is this comminuted, I'm concerned about length and rotation. Rotation, I think we have a pretty well-established set of tools to deal with, whether you're doing lesser trochanteric profile or neck horizontal, neck shaft angle, using the inherent inversion of a nail, which might be a good option for this type of case. But I think length will be challenging because you're kind of just guesstimating and hoping that those pieces line up back where they are, unless you really take some time before you start the case to plan things out. And then I think both coronal and sagittal angulation are particularly challenging for subtrochs. You know, we always highlight the flexion of the iliopsoas and the abduction of the gluteals and external rotation. And so if you don't bring that flexion out in some manner, however you choose to do that, and then you'll have sagittal angulation. If you don't have the right starting point and right trajectory of the nail in the proximal segment, your coronal angulation will be off. And then you're gonna be in big trouble. So this is everything's on high alert, big time from the very start.
So very good comments. So again, focusing on the head neck segment in the AP and sagittal plane. These are pretty good X-rays to show exactly those deforming forces. Which would you agree, Jeff? No matter what amount of closed reduction or traction, that especially sagittal alignment may not be reduced without physical manipulation?
Yes, no amount of axial traction will reduce that flexion.
Okay. And then I want you guys to think about entry points. So trochanteric starts, whether you're going to use lateral to the troch, tip of the troch, and like Jeff just mentioned, what trajectory are you going to use in that segment? Are you going to do just medial to the tip of the trochanter, or are you looking at more of an anatomic piriformis start to realign with the isthmus? So we're going to turn it over to Ed Westrick to go over some cases and discuss some very cool tricks and outline how he does how he gets these done right. Again, we encourage you guys to use the Q&A. It's obviously not, we're trying to make it a little more informal, so we encourage Q&A discussion. And Jeff and I and Ed are really excited to be here. Ed, you can share a screen. I'll stop and go ahead.
All right. Can you hear me okay?
We can't
Yeah,
see you, but
that's
we can
good.
hear you. Your camera's not on.
Got it. One sec. Okay. All right. So just picking up where Mitch left off, I just want to talk about positioning. Positioning for these fractures is either lateral or supine. Lateral positioning can be on a Jackson table or a traction table. It can allow easier reduction and access, but it can be more difficult and time consuming to set up, especially in larger patients. In my opinion, it can be challenging to obtain good lateral imaging, and the positioning itself may impart some valgus deformity as well as external rotation. And you can see in that picture the towel bump there to negate the effects of the valgus deformity. And the other issue is,
Ed, question for you.
yeah.
Are you have a picture of lateral? Are you really doing lateral positioning, or are you doing supine most of the time?
I'm doing supine, and I'll get to that in next slide.
Sorry to interrupt you.
Jump the gun a little bit, but it's all right. The other issue with lateral positioning is a lot of these patients have other injuries, whether it's a head injury, pelvic ring, acetabulum, some other injury in their profile that prohibits lateral positioning. So just before I get to what Mitch asked, fracture tables can be helpful for intertroch fractures, but I wouldn't recommend this for a subtroch factor for some of the deforming forces that Mitch and Jeff already alluded to in those first slides. The deformity is due to the muscle forces, and like Jeff said, traction alone, you can pull as much as you want, but it's not going to correct all of the deformity with these fractures. Being on one of these fracture tables means, especially the Hanna table shown there, while that's good for anterior total hips and some intertrochs, not so much for this pattern, and you're reliant on an assistant that is not really part of the surgical team. The circulating nurse, somebody not involved in the case. I would say the only caveat would be, if you really truly are somewhere out there on your own, you have no qualified assistant, this may be, your only option for traction. This can take the place of at least somebody, doing that. So that would be really the only time I could see this could be useful for a subtroch fracture. Do you guys feel otherwise?
I think it could be very helpful, but I think your point is good in that you shouldn't necessarily rely on the axial traction or the machined traction from the bed. And that I think a lot of us, the default is a closed reduction, and you're not really allowed to, or it's dangerous to do an open reduction. But I think, you can still do an open reduction with a fracture table, right?
I think it's more challenging. I mean, the most of the time with a fracture table, you don't have circumferential access to the leg, and you don't have the ability to freely position the leg in space, right? Part of the reason why lateral traction works is because you can control the distal segment and where you put it. And I think it's the same thing, if you're supine, you still want access to the whole leg. So yeah, I don't like fracture tables in general, but I especially don't find them useful. And I agree with you, Ed, on that. So.
Yeah, so my preferred position is supine, radiolucent Jackson table. Every member of the operating table, no matter if they do orthopedics or not, they're all familiar with this table. They don't need to do anything. We bring it in the room, and the surgery team does everything. I prefer to have the leg free, unencumbered access, and I'm in control of the leg and applying traction in any manipulative maneuvers. This is just a picture of this setup. And here you can see there's a bump under the flank to elevate the hip. The ipsilateral upper extremity is brought over the chest, and that's important that it's not brought across the abdomen. It's brought across the chest, and that allows unencumbered access to the buttock and the entry portal. And
So
this is just a
Ed, do you do anything special? Because I imagine in your neck of the country there are some people who are bigger in that part of the body. Do you have any special techniques? Because that's what the benefit of going lateral is billed as, is everything falls away. And I've done it a handful of times when people were pushing 400 pounds. But like you alluded to, it makes everything else so much more difficult. Do you have any pearls for me when you're doing the supine in larger folks?
Yeah, I think one thing is you can see the flank bump there, and that is a size of patient that we don't see in Western Pennsylvania. Usually our patients are 3 to 4 times that size. Some of them have a built-in bump, so to speak. But I think the bump placement, having the patient all the way to the edge of the table so that their buttock sags and hangs free and allows unencumbered access. Having the arm appropriately positioned, the bear hugger, whatever anesthesia is using is out of the way. You can see there that ramp is helpful to elevate the extremity. You can apply traction as needed, sterile inline traction. But, I think this is a part of the case that gets underestimated, especially by, the junior residents and, the junior residents really, that, you drape yourself out one time or you position the patient poorly one time, and it's a major struggle that affects the rest of the case. So I think paying attention to this step and having them appropriately positioned makes the rest of the case less stressful and easier. And these are already difficult cases.
Not to stay on this slide, but like if you're really paranoid or OCD, also this bump I would critique is not that good because it's folded, so it doesn't have a lot of density and it can get squished. So you really want to have a good blanket that's tightly rolled, that doesn't lose its shape. Don't make fun, I'm being serious. And then, like you said, not too big or too small. We discussed this with Matt Camuso. We're doing nailing last week, and go just past the edge of the skin so that the entry point is exposed lateral to the bump and lateral to the edge of the bed. So I agree 100%. And people who pay attention to that realize, oh, it's not that bad, especially if your starting point is at the iliac crest, right? If the patient is very large.
Yeah, we call it the butt cheek test, right? If you put your hand on the edge of the bed, their butt cheek should sit on top of your hand. Otherwise, they're not over lateral far enough.
And the other
It's a
thing,
Beverly Hills thing, I think. No, yeah.
You don't want the other extremity, moving as well, and you want to do everything you can to prevent the patient from sliding towards the contralateral side during the case. So you can't see it there, but the contralateral extremity is well padded. The Foley is well padded. The other extremity is taped and positioned appropriately. And then as far as your drapes here, you can see this is the pre-drape, but you have access to the entire limb, buttock, flank. The start point is unencumbered, and there you can imagine your hand, as Jeff just said, the Beverly Hills butt cheek test or whatever he called it, that would pass. So this is a good setup for the next set of drapes. And we'll just talk about more detail as we go through some cases. This is I'm going to try to show you a smattering of cases, and we'll jump around a little bit. But this case one, this is an 81-year-old lady, fall from standing, landing directly on the left side. She's fairly active, decent bone quality. This is more of an atypical pattern than you'd expect to see in the geriatric, severely osteoporotic patient that falls and lands on the side. So, large patient, segmental injury. You can see the spiral extending down the shaft. I felt, closed reduction or percutaneous reduction would be, really unsuccessful in this patient at, obtaining all those alignment parameters that we talked about. So I planned for an open reduction from the start. Based on her size, many might think that the greater troch start point would be easier to obtain and the preferred option. And this we'll call case 1A. This is a younger patient, high energy injury, motor vehicle crash. This patient also has ipsilateral distal femur and patella. And same thing, similar to the last patient, you can see the soft tissue envelope on this patient is quite large, bigger than the flat plate. Again, possibly greater troch start point, just for ease of obtaining it in a patient like this. Reduction techniques, I mean, all things are on the table, from closed reduction, percutaneous, different open techniques. But just jumping back to our elderly patient, we'll just call these 1 and 1A. They're very, very similar. Again, this is the elderly patient, and this is a trick that I find helpful for this situation. In my mind, the piriformis fossa start point is most appropriate for this patient to prevent varus deformity and help us achieve the alignment that we want. So again, preoperatively, I determined this was going to be an open reduction necessary to restore alignment.
Were you thinking like open reduction to control the head neck entry point, or were you thinking, like, I'd be a little, not anxious, but once there's comminution down the shaft, it becomes a little bit difficult to start. You start getting like obsessed with the spiral, and then you're putting a spiral back together, and then you're putting that back together to the shaft. So were you thinking more like head neck segment entry point, and you're gonna close reduce to the shaft?
Well, so my worry was actually the opposite. I was more worried about the shaft, and so I don't have all the images. You don't really need a CT scan, but here, this is really just the head neck segment proximally and a spiral distally. And so we'll have a contrasting case coming up to show exactly what you're talking about. But I think for this one, controlling the head and neck segment, that could be done through percutaneous techniques, Shantz pin, different types of manipulative wires and whatnot. So I'm pretty confident that all three of us, could get the start point, a piriformis fossa start point here. But then once that was done, realigning the proximal segment to the shaft was going to be more of the challenge. So that was, obviously the patient was asleep, and we, apply traction and use fluoroscopy and do the normal close reduction things. And when we determined after a couple, 1 minute fiddle factor that, that wasn't going to have the success level that we wanted, for me, I'm fairly quick to open. I think you can do an open approach and be meticulous with your dissection and your handling of the bone and the periosteum, and pretty expediently, certainly much faster in this patient. I can make an incision and get down to business and align this fracture really quickly, rather than fiddling with a number of different radiographic parameters and percutaneous techniques. So that was also another factor.
I think it's also just beneficial in the long run, right? Because this is an 81-year-old. You can see she has a really capacious canal, and if you leave it with that long butterfly piece down the shaft, you're going to have really poor fit in the proximal segment that we know is difficult to control. You're going to have a really long working length, and then you're going to pretty quickly transition past the isthmus into the capacious metaphysis. And so your alignment could be all over the place. If you get this reduced and you just put like a thoughtful cerclage wire, or you get the bone to contact, then you're going to have a lot of inherent stability that your nail can support. And so you're much more likely to be successful in terms of taking it to union without problems in alignment than if you just get it close enough, or, seems to be okay.
We'll bring this full circle with one of the later cases too, another example of what Jeff's talking about. But again, this is a easy trick. This is the same opening guide wire, through our incision for the open reduction, placing the guide wire up the intramedullary canal, heads straight for the piriformis fossa. So we easily pass the wire. It takes 1 second. And then, this is the opening reamer, the 8mm reamer. So we over-ream the guide wire, establish the start point. And so we know 100% that that is the correct, perfect piriformis fossa start point. And at that point, here's the reduction. You can see the lesser trochanter is comminuted, but the main three fracture fragments, fit like a jigsaw puzzle. Those are reduced with clamps, and then there's several meticulously placed cerclage wires. Again, those are not the tool of the devil. They're helpful in this patient with a long spiral and a large surface area. Those can be applied to the bone, with delicate technique and without damaging all soft tissue attachments. And so those help us, once we've obtained the reduction, those help us maintain the reduction. And at that point, we make an incision at where we normally would, proximal to the greater trochanter. And we've already established the start point. And so at that point, the ball tip guide wire is just dropped into the start point that we already established. And we've already established it in reverse. So, I mean, this whole sequence of events is really quick in the amount of time that we would use to put in 2 Chance pins to try to manipulate this. We're already at the point where we have a start point, the reduction, cables are going on and make an incision, and we're placing the ball tip guide wire, and from that point it's a sawbone. This is the other patient, back to 1A, and this is just another example. It's a different reamer, but the same exact thing. Again, this was the patient that had comminuted distal femur fracture, open patella, and some other issues. And so, although his pattern was much simpler, this was still a very useful reduction technique for him. If you
can I ask
remember,
you one question about that, Ed? And I was hoping to talk about this at some point, but when we talk about a piriformis fossa start point for proximal femur fractures, you can start in the true piriformis fossa like you have there, but particularly if you're using reconstruction style screws, then they go really P to A. I've taken to putting mine all the way up on top. It sort of really does blend into like a trochiformis start point. And then you're in line. Can you get to that spot from using that retrograde technique, or does it kind of tend to go out the true piriformis fossa?
it goes, I've only tried to go out the true piriformis fossa for these ones. So I'm sure you could if you tried. And again, you're establishing the start point. I think that could be done if needed. And then you're not passing, I mean, maybe somebody does, but I don't pass the ball tip guide wire, in retrograde fashion, then through the soft tissues, then out proximally through an incision that I made. So again, once we get the start point, we take everything out, line it up, proceed with the nail. So Mitch is on my case, so I'm just going to go a little faster through these.
Just said speed up a little. You have some good cases, that's all.
So this is back to the 81-year-old lady that we had the cables in, back to case 1, and you can see the final reduction there. This is another younger patient, 19-year-old guy in a motor vehicle crash, pelvic ring injuries, other injuries. He has a basocervical femoral neck as well as the subtroch. So I'll just get through these quick just for time's sake, because we have a lot to cover. And this is another one with the femoral neck and subtroch. This is one we plan to open, and we work through one interval for reduction of the subtroch, another interval for reduction of the basocervical neck. I don't have fluoro shots with them saved, but
so you did like a Smith-Peterson, an anterior approach for the neck, or a Watson-Jones type of thing?
Lateral incision. You work posterior to the vastus lateralis, elevate that, reduce the shaft, the subtroch, and then just anterior to the vastus lateralis, because this is basocervical. So Watson-Jones, you're right down on it, and this was very minimally displaced, and so not a challenging reduction, but still to look right down on it and know that it's reduced and not gapped or not rotated.
Jeff is going to talk about cables. Those cables, who are those? Like, who makes those cables? Not because we have a lot of conflicts, all of us, but I think we have enough that we're neutral. Who makes those cables, and how tight are you tensioning them?
All companies that we have available make them. And so usually, unless there's a hole in the set, I'm just using whose ever cables. I'm using their intramedullary nail. As far as, you know, each company has guidelines for how tight, how much tension there should be with the cables, and I'd refer you to that. But I would just note that all of these tensioning devices, there's a number of them, they all lose their calibration over time. And so for me, it's more of a feel. So this 19-year-old guy, maybe more tension than the 81-year-old lady. And so it's
and like, because you do a lot of revision arthroplasty, is it the same type of tension you're putting on it, or is this just to gather the fragments in, or this is the same for you?
Well, I'm not good enough to use the cable to actually get a reduction, so that's why you see I have pointed clamps everywhere. And then once I have it, I can get the cable on there, and so it's
Okay.
holding things in place. You know, where you know, for an arthroplasty case, I won't tension them until the final implants are in. Excuse me, I won't final tension them until the final implants are in. But in these cases, I need those tensioning devices out of there. They're in the way of our imaging. They're in the way of the aiming arm, the clamps and whatnot. And so I would say these are more for just maintaining the reduction. I think of these just like little round clamps that I can leave in there, as opposed to, you know, revision arthroplasty where, you know, maybe I'm applying more force to it. But again, back to, you know, I don't have an image with the wires, but these wires are placed to avoid the start point, the reamers, the nail, and also for eventually placement of additional screws for the neck. Just quickly, so we had touched on this earlier. This is a low velocity gunshot wound, isolated injury, also a larger guy. This is one that I know from the start, as far as reduction tricks, I'm not opening this. You know, this would be a struggle to open this, and this is massively comminuted, and none of these fragments are going to help with any of our alignment parameters. So this is one, you know, where we pay attention to a meticulous start point in all planes and controlling that start point and using a variety of percutaneous techniques. There you can see a bone hook, not shown, is also a ball spike pusher, and Shantz pins, a 2-pin external fixator. There's a multitude of different percutaneous techniques, and in my mind, this is the case where that's most beneficial. And again, here you can see his final construct, and we thought this guy had graduated trauma clinic and went on to live his life until 2 years later, very recently. He was involved in a motor vehicle crash with a new fracture through his old fracture in this bent hardware. Yeah, so this one was interesting. So what do we do now? You know, how do we get this out? How do we reduce it? How do we fix it? And you know, I felt we could get this out without any special tricks. We were prepared to cut the implant, and this is just an aside, critical piece of advice that's probably obvious to everybody that's on here. And I initially left a distal crosslock screw in, and my lovely team of residents and fellows let me wail on this thing for a good while before I made like first-year med student mistake and realized we still had a crosslock screw in it. So once that came out, the nail came out easy. And here's our reduction. You know, this you know, there was geometry to this fracture, but you know, really a segmental injury. We were just realigning it. This is where he was before the crash. Despite having a nail path there, getting the guide wire in was you know, quite difficult rather. And here you can see a tool. This is the honey dipper from this set. You can use a K-wire, whatever tool, drill bit, you know, some sort of blocking device to guide the guide wire, as well as the reamers. And then the next challenge was our fixation. And this is a guy that beat the implant once already. And so we wanted to give him you know, belt and suspenders to withstand whatever he's going to encounter his third trauma trip around. And so, you know, again, new nail, also a plate, you know, to allow him to go back to doing whatever things he does to get himself in these situations. Now, this is one we alluded to before. This is an 84-year-old guy from out in the country, very nice guy, treated in an outside hospital about 2 months prior to us seeing him. This is how he presented to us. And here you can see, the deformity here, as well as the broken implant. And then the question is, what went wrong? What led to this deformity? Did the deformity occur once the rod broke? And why did it fail? And I think this CT scan helps shed light on that. Just to click through this, you can see the position. He was basically just nailed where it sat. So no real attempt at any reduction maneuver. And you can see the deforming forces. Nothing was corrected. That nail was placed. There's no reduction. There's no load sharing with bone-on-bone contact, like Jeff mentioned. And this malreduction, malalignment is what led to the early failure in the nail to break. And so we did for him what should have been done the first time, took out the hardware, realigned this fracture, and new nail, different nail to avoid the previous lag screw path. And he went on to do great. And then this is my last case, just real quick, 37-year-old guy. This is a handful of years out. He was in a motorcycle crash, and there you can see him. He presented in the field, hair traction. These are his traction views in the emergency department, just showing the extent of the fractures. I couldn't, excuse me, I couldn't unarchive his CT scans, but I tell you, he has fracture lines that extend in that head neck segment to the greater trochanter start point, as well as in the vicinity of the piriformis fossa. So, Mitch, Jeff, any thoughts? What start point would you guys use?
Oh, you leave the easiest one for the end, but that's good. If they're cracks but extend into the start point, I don't mind putting in a nail. I know that there was a question about, do you always use the 8mm nail, or why don't you use the manufacturer's one? This would be a good one where I would use a 8mm nail, 8mm reamer or 10mm reamer, slowly through the entry point, and then ream up, even with a clamp around it, to not propagate the fracture line, and then put some reconstruction screws. Obviously, I'd need to study it a little bit more.
Yeah,
I don't think I would plate it is the other option. It's a bit too comminuted.
I think with this zone of injury and comminution, a medullary implant is going to serve you well. And so I agree with Mitch. I would, for this one, still tend to use a piriformis entry. At some point, I think we need to talk about the start point decision tree, but it's just a lot easier to tell what's straight down this versus what is 5 degrees off of straight on this. And then, probably some wires ahead of time, fully threaded Steinman pins, so that this can't slide and gap. And then just really focus on using, all the available tools again for length and rotation for this one. So.
Yeah, well, I mean, you guys are more skilled than I am, so I did the exact opposite of what you guys thought, and I plated it. Again, for me, and hopefully this highlights that there's no one right way to do any of these cases. There are multiple ways, and so I think in the decision tree, the algorithm can take you down different paths that are all can be good options. And so, it really has to take into account patient characteristics, the injury characteristics, and, all multitude of details. And so I chose the plate because I just didn't think I could successfully control all of those things. I didn't feel, I knew I could get the nail in there, but I was just concerned that I could successfully, realign all of his parameters in all planes. And so,
but what mode are you using? Because I see that the bones are being pulled in. Did you try to reduce? Is this somewhat loaded, these fragments down there?
Yeah, and there's
okay.
Yeah, so Yeah, so this is mixing modes. So that, things you're not supposed to do, but in a situation like this, kind of broke the rules a little bit. But but again, even with an incision and all of these fragments, you're respecting all these soft tissues. We're not doing the things that surgeons 50 years ago learned the hard way, and stripping all these fragments and taking out fragments. And so we're using the main fracture lines to reassemble and key in our reduction and establish all of those parameters. And he went on to do well. He healed and did well. So final images, and this was the we always say it, it's like cliche and corny, but in my hands, this was the best I could do for him. So
Thank you very much. Very, very, very nice. We're running a little over, but if there's any other questions, please please let us know. Jeff, was there anything else that you wanted to add sort of live quickly?
Right. So I think, there was a question in the chat box about when do you use troch entry nails? So maybe we should just bang that out now, because I noticed two things in Ed's presentation, which is number one, all of those were reconstruction style nails, right? So we'll commonly say cephalomedullary nail, which is a garbage term. It's either a reconstruction nail or a medullary hip screw for geriatric fractures. And so in all of those, Ed was using reconstruction nails, which I agree with, but maybe you want to explain why, Ed. And then when do you use a trochanteric entry nail, or why do you not use them? What does it take to get you there?
I mean, I think for me, in these patterns, these are more shaft fractures, the subtroch. And so there's a large head and neck segment. We know we want fixation into that segment. And so for, by using a trochanteric start point, nail with a cephalomedullary lag screw, whatever whether it's a TFNA, it's a Zimmer CM nail, Intertan, whatever the company you're using, whatever they call it, that nail that's meant for a hip fracture, so an intertrochanteric fracture, all these cases I showed were just not fractures that required a sliding screw up top. So that screw is meant to slide within the nail and compress and allow compression at the fracture site as the patient ambulates. And none of these patterns that I showed, that's not to say that's never the case, but these were just the cases that I chose out of 9 years worth. Jeff, I think you have one in your cases that we'll go through, but just for these ones. And so the reason for me, for these cases with the piriformis start point, that start point is in line with the canal of the femur, and we're not imparting deformity into the fracture. And so by using so the worst case scenario, things that could go wrong, is you're using a trochanteric start point nail. We start with a 17 millimeter opening reamer. We have a trajectory that starts, a point that starts too lateral and aims from too lateral to medial. And so then as we place the implant through that proximal segment, the tip of the implant goes back into the canal. We should add a drawing for this, I'm sorry, but our implant and our improper start point, our reaming path and whatnot, we impart varus deformity into the fracture. And so we could potentially be causing the worst case scenario in our alignment. And so for me, by having a piriformis fossa start point, I avoid that. And so even in these cases where I've obtained an open reduction, I have cables, I have clamps, that can all be ripped apart by using a nail, a troch start point nail, and then having poor technique, whether it's your technique or a patient factor or combination of those things. Just because we have it reduced doesn't mean it will stay reduced, no matter how many clamps and cables we have on it. So that's my
Yeah.
my spiel.
I'll just go through my case because I actually used a trochanteric entry nail. So this is the case we presented. Again, this is this case over here. So I ended up just getting length, and we described this last week, using a radiographic ruler just to assess what the length should be. Rotational profile using the other side, perfect lateral, and rolling up to an AP hip. And then again, I'm using the guide wire is a 2.5 smooth guide wire. I find it easier as opposed to threaded tip to get the trajectory and realign it. I'm using just medial to the tip of the trochanter. And I'm using, again, a bone hook to help with the sagittal alignment. Now here, what's important is I'm not happy yet. I have the good entry point, but I'm clearly aiming posterior. So I'm pulling down with my left hand on the shoulder hook, and then I'm going full speed and adjusting the reamer without advancing so I can get a good trajectory on the lateral. But I am very nervous at this point. I will not proceed because, like Ed just said, once you create that path, it's sort of game over, and it's very, very, very difficult to fix.
And there are bailout maneuvers for that. I'm sure most of the people on here have seen the Harborview tips and tricks. It's right on the cover. There's a lot of fancy bailouts if you have an errant start point, but I think the goal would be to just not get to that point.
Yeah.
That would be, in my mind, something that I would want to save for my country guy that got messed up at the other hospital. I don't ever want to have a start point like that. So it's a lot easier to get the start point and not have to use some fancy trick that you read in a book. These are real patients with real medical problems that are under anesthesia, and so while all this stuff can look cool and it'd be nice for a presentation in a book chapter, I mean, the goal is to not get to that point. And by what Mitch is showing you here, taking that extra 1 or 2 minutes here, potentially saves you a substantial amount of time correcting a mistake.
Yeah. So never ream an unreduced fracture, and it's about that trajectory. So.
All right, we're gonna go over to Jeff. I'm gonna start answering some questions, so keep them coming. Jeff will go over some cases, and then we'll finish off with a journal article.
Oops, wrong one. Oh man. Sorry, I had it before. There we go. Okay, so I just have two cases that I thought illustrated some points. So this is a 90s something gentleman. You can see that the years of hard living in his vasculature there, who has this what's probably a subtroch, but doesn't exhibit the classic deformity, but a relatively proximal spiral femur fracture. So Mitch, do you have any concerns, thoughts, questions about this case?
I was just answering questions, but that's fine. Yeah, one is for me, it looks like a simple fracture pattern. So I'm right in my head at first off, I want to do an open reduction because it's simple, and I want to clamp it. So that's one option for me. The other, sometimes I get nervous, even though it's a load sharing device, these folks don't have the highest healing rates. So even with a gap, I find sometimes the compliance of the fixation is wrong and they develop atrophic non-union. So I like to get them reduced. The other is, what kind of bowing does the patient have? If the patient's like 90, and we always have these fragmented x-rays because it's trauma, is there a bow in the coronal plane? I worry about as well.
Yeah, so to me, a similar thought process, right? This is a 90-something-year-old. He's got reasonable cortices, but this is a long, simple fracture. And so like we've all talked about already, I think an open reduction will save you lots of time and help you get this right. In addition, so you can see, again, just like Dr. Westrick, I put on a couple clamps and reduced this. The cerclage wire that I placed, just a single thoughtfully placed cerclage wire, is actually just a regular old 18 gauge wire. And then rather than using big tensioners from an arthroplasty set, I just put both ends of the wire into the collet of the pin driver and I spin it, and it will slowly tighten down. You go that real slow. You have to get it started a little bit because like in the old, videos of doing a tension band, you don't want the wires wrapping around each other. You want them actually twisting. But once you get it started, it'll go. And then at that point, again, it's a
wow, that's an amazing. That's so amazing. Why haven't you told me about that move?
I don't know. I didn't invent it, but somebody showed it to me.
Why do you guys think? Why do you think people are so afraid to open these fractures? Why they will be scared to death to open a fracture because of something they heard about fracture hematoma at some point in their training.
I don't know. Well, that's what we have for Journal Club. The journal articles we're going to talk about later to go from that. But I think it's about the fracture hematoma, or just that sounds very bloody. I know these are old people. They think it'll be faster. There'll be less blood loss. I would argue it's the opposite. The just opening it, clamping it, right? Even if you struggle for a little bit, it's still faster. So, and then, so a couple things on implant selection here. So I would venture that in a fracture at this level of the diaphysis, you could choose any sort of proximal fixation you want, but in a 90-year-old, you want fixation into the head to protect the femoral neck. And so similar to Ed and Mitch, I strongly prefer to be in line with the canal. I think everybody's proximal femoral geometry is unique. And so what somebody's head-neck trope relationship and a different person's head-neck trope relationship will be different. And every nail is different. So you have to know your implant at your hospital really well, but you also have to recognize problems with the patient. So you can see here, even though I'm just medial to the tip of the troch, I'm already aiming back laterally just to be in line with the canal. And then on the lateral view, I always try to bisect the neck on a true lateral. So I don't like to start in the piriformis fossa. I like to be bisecting the femoral neck because that way my screws will be central. And if I needed to use inherent inversion for a really comminuted fracture, I've preserved that option, even if I'm using a troch or a piriformis start point. And so again, you can see here, we did use a piriformis start point and got what I think is good alignment that's satisfactory. But I mostly wanted to highlight the points about the geometry of the proximal femur implant choice. Just like Ed said, this is not a case where we need, even though this is a geriatric patient, this is not one where we need his neck to slide and collapse along a sliding hip screw. The other thing is that, for me, cerclage has been an evolution. When I started, what we were taught in fellowship was cerclage is the sign of the desperate surgeon. And I think that can be true. We've all seen those like disasterplasty cases where there's just cerclage all the way down the femur. But particularly in these elders, having a nice single cerclage wire, in addition to getting it reduced, also prevents that femur from expanding, which it necessarily has to do if it's going to displace around a canal or around a nail. And so I think that's a really helpful tool for these people. I don't know, any comments, Mitch or Ed?
Yeah, so one comment, just for thought is hoop stress and being slightly anterior. So I think we should, I don't know, we don't necessarily have time to discuss it, but being collinear with the canal in the piriformis fossa and moving just anterior to it, it should increase the risk of iatrogenic femoral neck fracture. Was that fair to say, Jeff, or not necessarily?
That's what we would extrapolate from old nailing. I would argue that in modern nailing, we don't have any reports of that. So while I'm certainly aware of it and cognizant of it, knock on wood, that's not been a problem for me. The other thing that is really nice, particularly as you get older, is you brought up the bow, but by bringing your starting point just a little bit anterior, now you're starting from anterior and going down the canal. If you start from posterior, the end of your nail is going to inherently be slightly more anterior, which increases your risk for anterior cortical breach in the distal segment, which we know is an issue as well. So
Okay.
I've been happy with that.
Another question, Jeff. A comment on this concept of disturbing the endosteal or intramedullary blood supply, and then you're going to do an open approach, and now you're disturbing the extramedullary blood supply. Like, isn't that bad to do an ORAF plus an IM nail? Right.
So you would think so, but again, it's all about the soft tissue handling. And so if you do a very nice subvastus approach, I don't just bovie through the vastus, carefully elevate it, leaving the periosteum on. You don't need to strip much of the periosteum at the cortical reed, and then doing a single nice pass of the wire, I think does not disturb it very much. There's a couple papers out there. Tim Weber has one that he's publishing. There's another one from a European group, or a East or West Asian group, about the same thing, where they saw actually increased union rates with a thoughtful cerclage algorithm. And so I think when you have these long spirals, it can help with the reduction, and it can definitely do a great job of maintaining the reduction, until the implant's in.
Well, Jeff, just to elaborate on that, I mean, these long spirals in these elderly patients, when we do open them, what you find is they have all this muscle interposed. And so a couple things: if we leave it in that position, or you obtain a closed reduction and it's not perfect, then we have interposed muscle, we have a large gap. You likely, you have to, by definition, have some sort of deformity, whether it's rotational or shortening or whatnot. And so all these factors in patients that, like this patient, that artery has more calcium than the bone. And so these patients have every factor going against them. And so if we leave a mal-rotated, mal-aligned limb with interposed muscle, we've not, we've contributed to that. And so bone doesn't want to, there's not much bone in this patient. They're borderline, invertebrate. You don't want to leave a big gap where this bone has to bridge from one side to the other. And so in my mind, that makes complete sense, that having this anatomically reduced, I'm certain you've left all the periosteum on there, not stripped anything. You've not done anything to jeopardize the blood flow to this bone. Certainly not anything more than the fracture has done to it. Now you have it perfectly aligned. It can load share. This patient can weight bear immediately. There's no muscle in there. And so everything you've done here is promoted healing and early ambulation in this patient.
Yeah. So
I just had one more comment, Jeff. I know we're really running. We're short on time. We're going to finish on time, though. The question about plate, someone's asking about plating versus IM nailing of femur fractures, and I think in general, and I'd be interested to hear what Ed has to say. In general, I think IM nails are better implants for subtroch femur fractures. They're load sharing, they're centrally located, especially if you're plating on the lateral cortex and it's in a bridge mode construct with a lot of comminution. I don't think it'll hold. Now, when Ed said he plated that subtroch, he didn't say, he did say, I guess, it was in neutralization mode, because he effectively reconstituted the diaphysis. So Ed, were you thinking that? Like, were you never going to put that plate in bridge mode for that amount of comminution?
Correct. Yeah, that was, I knew what I was getting into there. And to answer the first part of your comment, I would prefer a nail for every one of these. I think that's a preferable implant in my mind, except for that one case. I could think of in all the years, less than a handful of cases where I've done a plate for these types of fractures, and that happened to be one of them. Other cases are, they're unique cases where there's some arthroplasty implant or some, long stem revision need, things like that are, outside the normal scope of what we're doing day to day, and really for another lecture. But to, I think we all agree on that. I mean, nail for these injuries is by far preferable over a plate rather.
I think the literature would back that up as well. It's just an issue of occasionally there are some things about a particular case where you need to go from there. So different case here. I'm going to kind of skip over this. This isn't like a look how awesome this is case, but just a highlighting the importance of doing things right. So this is a woman who came to me after having an atypical femur fracture. It was treated in an outside hospital. And I don't want to talk about atypicals because that's a whole nother discussion, but you can already see here there's a pretty profound varus deformity. This is a straight nail that was placed through the lateral to the tip of the trochanter. Right. When you look on the lateral, you can see that same flexion deformity that we've been accustomed to seeing. So that was flexed up and it was not reduced. And so she had a non-union, and you can really see it there. So, there's a lot of talk about starting points. And so again, I think being central in the neck, and no matter what you're doing, whether you're doing a trochanteric entry or a piriformis entry, you want to be medial to the tip of the troch. So maybe the other paper we should have picked for Journal Club is a paper by Struble et al. In 2011, where they templated out using one particular company's medullary hip screw. So not a recon nail, but a medullary hip screw. And 88% or 80% of the cases, the start point was at or medial to the tip. So I'd happily err in those 20% and cause a little bit of valgus than I would mess up for the other ones. And so
I just want to add a point also, because I think there's a lot of questions also about a troch entry nail versus a piriformis entry nail versus the cephalomedullary recon business. The learning point is, like you just said, Jeff, choosing the nail is not necessarily the hardest part. It's ensuring your entry point and trajectory in the head neck segment is right before you put that nail in, or make sure that trajectory, especially on the lateral, is collinear with the canal, because once you do that wrong, it's almost impossible to get right.
So this is just one example of correcting that. So this was a very anterior and lateral start point. So we filled it with a allograft fibular strut, and then open reduced the fracture, corrected the alignment, and then here we are getting an appropriate start point. And here's the end result of a fracture that was loaded with this articulated tensioning device and this lateral fracture to bring it out of varus, and was corrected in the sagittal plane as well, and getting a new start point. So we're kind of up for time, but I really want to highlight the importance of getting the correct start point and the correct trajectory in the proximal segment. So you don't necessarily have to have the fracture reduced, like Dr. Bernstein showed, if you're reaming along the correct trajectory when you open it, and then you get it reduced before you pass your other reamers. But you need to be the right starting point, the right trajectory, and then have it reduced while you're passing your reamers.
Great. We have a very good question. A really, really, really good question. Okay. So the question is, in the 9-year-old patient where you used a reconstruction type nail as opposed to the geriatric nail, aren't you more concerned about implant cutout with the reconstruction nail? And I think Ed Westrick alluded to this, but if Jeff, you want to chime in on that comment. I think it's a very, very good question.
Say it one more time.
Okay. You basically have a 90-year-old and you're not using the geriatric type of nail. Aren't you concerned with cutout of the reconstruction screws in the head neck segment for a subtroch.
No, I mean, I think the Z effect is real, but it's also, again, somewhat historical because we've learned to leave our proximal screw shorter and try to avoid that. So if your caudal screw that's more medial is longer, you should be able to go from there.
And you also, yeah, Ed, do you want to comment? Because you also mentioned the you know, an inner troch versus a subtroch, right? That comment.
Yeah, a couple points. You know, one, if you were using this nail for an inner troch, cutout that was the question would certainly be an issue. But again, you know, this is a subtroch non-union, and so what we want here, as opposed to Jeff, go back to the initial fixation, you know, where there's only one screw that is not really controlling the head and neck segment, right? And so what, you know, in this pattern, a subtroch, I would argue you need more than one screw, and you need the recon style screws. So for a subtroch, you know, having the recon style nail with two screws, that you really shouldn't have a cutout pattern. You know, there's no inner troch component, there's no compression of the fracture site. You know, none of that should be an issue. And then the other way to think about it is, you know, every company is a little bit different, but the cephalomedullary lag screw for some of the companies is whatever X diameter, but you use two of these reconstruction style screws, and they're each 6 millimeters, which ends up being more volume and bigger amount of screw. I don't know what you want to call it. You know, there's more there. There's more metal there than if you were using the lag screw. And so, you know, back to, you know, if this were an inner troch and you're using this nail, I would expect that to cut out and fail. That would not be ideal. On the flip side, for this subtroch pattern, you know, I would not expect this to cut out. I would not expect it to fail. You know, somebody had mentioned in the questions, I saw their hospital only has hip nails. And so I think if that's all you have, certainly, then that's what you should use. And, you know, I think that's acceptable as well. But like Jeff has highlighted with these cases, then, you know, maybe that means, you know, that's even more reason for you to be just absolutely meticulous with your start point and your reduction and all those factors, you know, everything Mitch and Jeff have talked about throughout this webinar.
Okay. All right, so I don't have more there, Mitch. Do we want to go to the journal club, or are there any other points we need to make?
Let's go right into the journal club, and then we'll, because it's going to be short, and then we'll just shut it down with questions. A lot of very good questions. I'm trying to keep up here. I don't know if Ed has time to show any of his cats. That'd be an appropriate time right now. I guess they're not in the room.
There are no cats in the room.
Oh man. Really struggling with, I'm a Zoom rookie just like you, Mitch.
I guess we're all rookies. One question about a blade plate in a subtroch non-union for a redo femoral nail. I think the short answer is they both could work. And I guess it depends on, you know, how old the patient is. Can they withstand some non-weight bearing for, you know, 6 weeks? Is the head, what's the status of the head neck segment bone? How good are you with blade plates? Do you like using them? Because you can really load the fracture with the blade plate. So again, I think it's like we talked about what's good in your hands, but I think there's a lot of cases that a blade plate works very, very well.
Yeah. I agree with you. I personally like you know, plate assisted nailing, that like you saw there. I feel like I can really tension it, and then I still get a medullary device. But I think a blade plate also works very well, whatever you're facile with. It's not, each is not the same. So I'm gonna highlight two journal club articles here. One is this paper by Alan Afsari from 2009 that was published in JBJS. The other one is a paper that was published by our from Harborview in 2013 by one of our co-fellows, John Scalero, and some of the faculty there. And they're both about open reduction. And so, this first paper, Dr. Afsari's paper, they had 55 patients, 44 of those had follow-up, so about 80%. And all but one of those patients who followed up had union. The technique that they were proposing for people was basically taking a clamp and sticking it in through a percutaneous incision, and then using that clamp to bring the fragment down out of flexion and out of varus into neutral alignment and valgus. And then through there, they would then perform their nailing. And so this technique was pretty successful. 85% of patients had what they called an anatomic reduction, and every patient was within 5 degrees. They did all of these patients or surgeries supine, and specifically said, we didn't decompress the fracture hematoma intentionally, but it sort of unintentionally happened. But basically pretty reasonable results, high union rate in a fracture that's prone to non-union, and pretty good alignment using devices to help restore alignment. And I bring this one up just because, a series of 44 patients that was just the level 4 evidence made it to JBJS in 2009, because this was pretty revolutionary to people. There was so much of this discussion about don't violate the hematoma, don't open it up, you're going to disturb the healing, that I think this was kind of paradigm changing for people. And even just sort of, like they said, a clamp assisted, this isn't even really open reduction, this is just a baby step toward open reduction, was pretty newsworthy. The second paper, a few years later in 2013, they reported on an 8-year period in all the subtrochanteric femur fracture patients that they treated during that time. 96 of those 154 patients had adequate follow-up. And then out of those, almost 60% were open reductions. And these are, I think, what we would consider more formal open reductions. You can see the picture on the other side with a very anatomically reduced fracture. It looks like one of Dr. Westrick's slides that he showed us. And then these patients went on to receive medullary nailing, and they had a 100% union rate with no infections. Their alignment was perhaps a little bit, or was comparable, 82% versus 86% anatomic alignment. All but one were within 5 degrees of alignment. And again, this was a supine surgery on a radiolucent table. And so, really when, again, another paper showing that open reduction, when done carefully and thoughtfully, is a useful tool. And so I thought these two papers, a couple years apart, that show sort of incremental steps towards open reduction is useful, just because, over and over again, the problem with subtrochanteric fractures is not that we don't know what implant to use, or we don't know that they're hard, or we don't know what muscles are the deforming forces, but that we don't get an adequate reduction, or we don't maintain that reduction to the end of fixation. And so an open reduction, I think, is really useful. These are hard cases. Trying to do these all closed is going to really challenge you, but when you get an accurate reduction, you're going to have good results, and an open reduction is a safe and effective way to do that.
Thank you, Jeff.
That's all I have.
All right. So I'm going to share a screen, and we'll answer some remaining questions. Okay, so there's a question about Tim Akers' approach of using a Metatan 5-degree nail and inserting it at a trochiformis start site to avoid varus. Upstanding that this is a technique was specific for atypical femur fractures. What are your thoughts on this?
I don't think that's I mean, I'm sure Dr. Aker employs it very well, but it's not, I think a trochiformis start point is desirable in almost every case. Like we talked about, 80% of the time, the correct start point is medial to the tip. Whether you're using a piriformis nail that is going to go down the canal, or you're going to use a troch entry nail, for me, that it's almost the same exact start point. If you would usually what I'll start a case thinking I'm going to do a piriformis, and then if they're really big, maybe I can hit the start point but not get the right trajectory. Or if it's my reduction is not as good as I hope and I want to kick it into a little bit more valgus, then I'll switch to a trochanteric entry nail and yeah, use that same thing to push it over. So I think that works very well. And it's a good way to try to fix that from the start rather than backing it out, doing blocking screws, re-reaming, other stuff like that.
And again, just to clarify that, because a lot of people may not know what this word means, trochiformis. Again, the idea is an IM nail the entry point of your IM nail should eventually be collinear with the anatomic axis or the medullary canal. What we're trying to say is, and what's been shown, a trochanteric entry nail is almost never collinear with the IM canal, or technically as a surgeon, it is very, very difficult to be collinear with the canal. So because you're not that good, in general, we are not that good, we err on going erroneously to medial, and that will induce a valgus deformity as opposed to a varus deformity, because subtrochs are very sensitive to varus malreduction due to the high tensile forces on the lateral cortex. So I think that's the concept with this trochiformis word, meaning you just make sure your entry point is not at the tip and definitely not lateral to the tip of the trochanter. Ed, who's that? There was a personal question for you about, is that what you're?
Yeah. Doctor, shout out to Dr. Matt Bologna.
Yeah.
Appropriately placed cryptocurrency question.
With plating of a subtroch, would you let the patient weight bear?
I mean, I think the patient I showed, I did not let weight bear for 6 weeks or so. I mean, he was touchdown weight bearing. Honestly, I mean, there's so few and far between. It would depend on the specific patient characteristics and their other injuries and the type of, fracture pattern. If it was, I don't know, for example, the gunshot, massively comminuted femur with bone loss, if for whatever made up reason I had to plate that, I would, for example, make that patient touchdown weight bearing, versus, the first patient I showed that, we had opened and, compressed and clamped and perfectly reduced. And it was the difference between her going to a nursing home or going back home. Those patients I would let full weight bear. So I mean, every patient's different. Their constellation of injuries is different. Their social situation is different. So all those things matter. So it's hard to make a blanket statement. But in general, we're taking these patients to the operating room, and we're doing it for a reason. And I always try to lean on the more aggressive side with weight bearing.
I don't know you or Jeff, who has larger patients, Pittsburgh or California, but talk to us, because we didn't glaze over it, but how do you get a piriformis start point, really, Ed or Jeff? Because there's a question about, is it really easier or harder to get a piriformis? Is it easier to get a trochanteric start point? And then, like Jeff said, how do you make sure the start point's good, but also the trajectory? You have like 3 minutes to discuss that, please. A very important question.
Well, I mean, we're discussing whose patients are larger, or
no? How do you get the right start point and trajectory, specifically piriformis, let's say?
Yeah, I mean, I think for the piriformis, I mean, it's a good question. Every patient's different, but I mean, one thing in general is, just going back to the first slides, your prep and drape. The bigger the patient, the more proximal your start point is going to be. And so if you drape out the patient and you think you're going to make an incision, if you need to do a piriformis nail and you hose yourself with the drapes and your positioning, and you're draped out and you think you're going to make an incision where you might for a 100-pound little old lady intertroch fracture, you're going to be, sadly disappointed with the way the rest of the case goes. The bigger the patient, the more proximal the incision goes and your trajectory. But I think those are patients where you really need preoperatively to have every possible tool available to you, whether it's again, these fractures are challenging because just applying traction isn't going to affect a reduction. And so you need to correct all of these deforming forces. But the bigger the patient, the more likely I am to, my fiddle around factor, the amount of time goes up, because I'm not too keen on making an incision where I'm going to be elbow deep in a patient's thigh.
A couple other things is in general, but especially for obese people, in addition to starting more proximally, I think establishing a start point before you apply traction is very helpful.
Mm-hmm.
So you can, especially if the leg is free, right? You can't do this on a fracture table, but if the leg is free, you can adduct the leg. You can put a Chance pin in and use that to really bring the proximal femur over. And then you can, again, like Ed said, start really high, and that'll bring that over to you to help you get not just the starting point, but the trajectory. The other thing, like I said, is Ed showed where there was talk about this smaller reamer. So whether you're using an 8 or a 10 reamer, as long as you're not using that big 14, 15 millimeter reamer, if you're at the right start point, you can start it going. And then as you showed, Mitch, you correct your hand, and that can then get you to the right trajectory. So get the start point, get it over where you want it, get your B-tip guide wire in, and then you can bring it back, apply traction, and get the rest of length and rotation. Just like Ed showed, he got the start point at the very start. Maybe you're not opening and going retrograde, but you can still get that before you do anything else to the rest of
the last comment is, like each step, don't proceed to the next step until you're happy with the first step. And it starts with positioning. Ed had 3 slides on positioning. So if the positioning is not good, don't proceed to start draping, because then I think it just gets more difficult. And then final comment is paralysis. I have to tell you, in fellowship, they used to say 0 twitches all the time to the anesthesiologist. And then I thought it was pretty obnoxious, but if the patient is not paralyzed, I find the case is not possible. And I hope there's no anesthesiology people online, but they lie to you. They lie to you and say, yeah, because I don't think they like us, but they lie and say the patient's paralyzed and they're not. So now I typically I'm a little bit more aggressive about paralysis.
Yeah, no. Or you ask if they're paralyzed and they say yes, and then they're not, you proceed, and then the patient's muscle contractions are kicking off the clamps, and then what paralysis means from one CRNA to another is quite variable.
You have to ask specifically for 0 twitches.
Yeah, we ask for -5 twitches, and then we get to 0 from there.
All right, guys, we're going to shut her down here. I want to thank you guys very much. A link to the recording will be sent out 24 hours after the conclusion of the webinar for all of you who have registered. You can access those. And we have these amazing YouTube channel, AO North America, where there's a really, really very good content out there. Take-home messages, like Jeff mentioned before, subtroch femur fractures are challenging. Inserting any type of cephalomedullary nail does not guarantee successful healing. And I think we talked about success is dependent on accurate reduction when treating subtroch femur fractures, and open reduction is safe to get your alignment. There's some upcoming sessions next week, supracondylar femur fractures, and then we're moving to the upper extremity and then back down to the tibia and the ankle at the end. Thank you guys very much. Jeff, Ed, a pleasure, a real pleasure to have you. And we'll see everyone hopefully next week.